like to welcome you to this edition of the award-winning PRS Journal Club podcast with your hosts, Drs. Francesco Egro, Nicole Phillips, and Ira Savetsky. Enjoy.
Hi, everyone, and welcome to the May 2018 edition of the PRS Journal Club podcast. I'm Ira Savetsky, PRS Resident Ambassador from NYU, and as always, I'm joined by my co-resident ambassadors, Francesco Egro from the University of Pittsburgh Medical Center and Nicole Phillips from the Harvard Plastic Surgery Program. Today, we have the honor of being joined by Dr. Vu Nguyen, Assistant Professor of Plastic Surgery and Residency Program Director at the University of Pittsburgh. Thank you so much, Dr. Nguyen, for joining us for this PRS Journal Club podcast.
Thank you for involving me.
The article we'll be discussing is Cheek Volumization and the Nasolabial Fold by authors Drs. Lambros and Donald Mowlds from the University of California, Irvine. A quick reminder, all of the articles that we will discuss can be read for free on prsjournal.com, including an archive of all past Journal Club articles. To begin, the use of volume for the aging face, whether it be with filler or autologous fat, has been arguably the single largest improvement for facial rejuvenation since the facelift. With volume, facial contours and balance can be altered non-surgically to be more aesthetically pleasing in a relatively safe manner. There are individuals in the facial injection community who believe that cheek filling results in longitudinal shortening or a, quote, lift of the skin and elevation of the nasolabial crease or nasolabial fold. However, this claim remains unsubstantiated. Given the increasing prevalence of cheek fillers and the availability of 3D photography, the authors sought to examine this more closely. The goal of the study was to see if cheek filling made visible changes in the nasolabial fold and whether a displacement of skin could explain the difference if it occurred. In the study, 77 patients were evaluated pre- and post-injection of the cheeks with an hyaluronic acid filler using a three-dimensional camera system. In order to demonstrate the relatively pure effect of cheek filling, patients were evaluated for nasolabial fold differences only if their lips, nostril base, or nasolabial crease moved by less than 1 millimeter between images. In terms of results, placement of filler resulted in expansion of the skin outward from the center of volume of the injection, analogous to dots on an inflating balloon. When seen from above, the dots will spread in all directions. This is seen in Figure 2, and there's an animation available. This pattern was reproduced in all 77 patients treated. Of the 77 patients, a subgroup of 37 patients with stable facial expression were used to determine the effects of cheek filling on the nasolabial crease and nasolabial fold. By direct comparison, none of these 37 patients with isolated cheek injections showed evidence of lateral traction or, quote, pull on the skin between the cheek and nasolabial crease. In addition, there was no difference in the nasolabial crease or fold position following injection. The only patients who demonstrated photographic improvement of the medial face were those who had filler placed directly in the transition between the lateral nasolabial fold and cheek, or the nasojugal crease. It is likely that expanding the nasojugal crease is the direct cue that leads to perceived improvement in the nasolabial fold. Overall, I think this was a really great study. The authors did an excellent job in standardizing and analyzing the images in what appeared to have been a very tedious analysis. Patients often come to the clinic asking for a, quote, non-surgical facelift, and as the authors point out, the word lift is used in many different ways and in different contexts. It can be used to describe a change in position of skin perpendicular or parallel to the plane of skin. The authors, and I think we as plastic surgeons, typically use the term lift to describe a traction force parallel to the plane of the skin as in a facelift. I think it's important to have an in-depth discussion with our patients as to what their expectations are with the addition of volume. The key finding in this study was that filler expansion of the malar and submalar area of the cheek creates an elevation of the skin surface that increases the surface area of the expansion and does not create the traction forces on the skin remote from the injection. In fact, the opposite occurs. The expansion of an area injected in the subcutaneous plane moves radially outward as seen from above rather than radially inward. The authors note that a population of patients that showed photographic improvement of the nasolabial fold were those who had filler placed in the nasojugal crease, the transition between the lateral nasolabial fold and cheek, which often hollows in patients who thin as they age, and this visually separates the cheek from the nasolabial fold, and by expanding this area directly, the separation is minimized, and thus looks very similar to a cheek which has been pulled. Lastly, I do like the author's general rule of thumb for filler in young versus old, which is that in young faces, they benefit from filling prominences, and older faces typically benefit from filling hollows. Dr. Nguyen, I'm curious to hear some of your thoughts about this paper, and then how do you counsel patients that come in to your office requesting a, quote, non-surgical facelift?
I thought the paper was really interesting in that, again, it's trying to apply some objective measurements to what's oftentimes seen as a very subjective field. In regards to your question about counseling patients, I think aesthetic surgery, as many things in plastic surgery, has undergone a real revolution, and techniques and approaches have had to change with that. No longer are we surgically lifting patients and just tightening the face, for example, but the notion has been now to provide more volume and provide a more gentle lift or a more gentle surgical approach. And that has been reflected in patients who no longer want to seek an operated look or have a dramatic change in their appearance, but want to have a more rejuvenated version of their own self. They want to be able to recognize themselves in the mirror, but look like they did 5 or 10 years ago and not see someone foreign within the mirror. And I think the trend, certainly the significant trend towards non-surgical techniques, or even something in the middle, for example, like fat grafting of the face, has really been on point in regards to that transformation of patients who want a more rejuvenated look versus a very operated look.
Yeah, I think those are all really great points. Francesco, what did you think of this paper?
Thanks, Ira. I must admit that I had mixed feelings about this paper, and hopefully I won't get shot for it. I appreciate some useful pearls on how to tackle these filler injections, like the role of local anesthetic solution infiltration prior to injecting the filler, and I thought that was a pretty nifty trick. I also understand the message that the authors are trying to convey in an objective manner, which is to break the misconception that cheek injections cause a lateral traction effect of the intervening skin and thus have no effect on the nasolabial fold and crease. However, I don't feel that this can be concluded from the study due to the lack of mathematical quantification of the changes. For example, the authors state that there was no difference in the nasolabial crease or fold position following injection, and that the nasolabial crease did not move unless the lips moved as well. The authors don't really specify how this was quantified or calculated. And they also stated it did make a difference if filler was injected premalar or submalar. And again, how was this determined or quantified? To Dr. Nguyen, I'm noticing that more and more studies are using 3D imaging for cosmetic outcomes, but I wonder whether it is accurate enough to detect such subtle changes. And what are your thoughts about these 3D imaging techniques, and do you think 3D imaging holds a pivotal aspect role in the future of cosmetic surgery research?
I think 3D imaging is going to be increasingly important for us to assess our outcomes, to look at volume differences, to look at changes that we make operatively that we only kind of subjectively say make a difference. So I think it's going to be increasingly important. As you had mentioned in this particular study, they're looking at very minute changes that maybe based upon our current technology or our current methodology, we might not be able to see those objective changes at this point. So I'm not sure how accurate the 3D imaging in this particular article supports their hypothesis.
And I think the authors did a great job with the images. You can really see the pre and post injections, and it makes a very convincing argument. I just wish that they had perhaps quantified that changes a bit more. Nikki, what are your thoughts about the paper?
You know, as Dr. Nguyen pointed out, this is really one of the fastest growing trends in plastic surgery. And so I think it's something that for us in training, we really need to be aware of it and, sort of stay on top of the research that's happening around it. So I think this is a good paper to turn our attention to this. To get back to the question of patient expectations and what people come into the clinic looking for, I think there are a lot of great things that we can achieve with non-surgical rejuvenation, but there's obviously a limit to what we can achieve. And I think that's maybe part of what this article is getting at. And so, Dr. Nguyen, I'd love to hear your experience or your thoughts on when a patient is wavering between surgical versus non-surgical options. Where do you draw the line and say, listen, we're really looking at something surgical, or how do you guide them through that decision?
It's interesting because I think in my practice, where I have an academic practice, I don't have some of the same financial pressures to operate that might be present in a practice that looks more at the bottom line. So from that point of view, I have the luxury of approaching patients and trying to determine what their goal is. Again, do I think they operatively need a more surgical technique, or is this something that could be accomplished and temporarily be treated with injectables? Or is it a situation where oftentimes they can benefit from a little bit of both? So again, an operation combined with injectables in order to maximize the output of that operation. A lot of that comes down to the patient and their individual factors in regards to age and the level of either deformity or the level of change that they want. and what the inherent costs and the downtime are. So again, the wonderful thing about this is that it ends up being a very collaborative approach with the patient in regards to assessing their expectations and then assessing their ability to tolerate the surgery, the recovery time, and also the inherent costs versus defraying those and temporizing them for a result that they could accomplish, downstream.
Absolutely. I think that's bringing up an important point as well, which is that it might be, an issue of timing, and maybe there's one option that's right at this particular time for a number of reasons and can always revisit it later on. So thanks very much for your thoughts.
Ira here, what Francesco mentioned, what the senior author, Dr. Lambros, does by injecting a dilute local anesthetic so that patients sort of get an idea of how they will look, sort of like test driving a car before buying it. I think it's a useful technique. I've never done it, but it sounds like it makes a lot of sense, and particularly for patients who are indecisive or virgin. My personal concern with that, maybe it would potentially distort my field of injection. Nice thing about fillers, for example, is you don't have to wait for a result. You may have to wait for some swelling post-injection to go down, but as a whole, you sort of see what things are going to look. What are some of your thoughts about Dr. Nguyen? Do you think that, or at least in inexperienced or residents' hands, may not be so good to start off with?
Yeah, I think it's an interesting technique, both from a point of view of, like you said, of not only from the practitioner point of view of trialing it to see what the benefit is with a saline injection, and also for the patients to literally try on that injectable. Obviously, Dr. Lambros has a lot of experience, and he has built up the experience where he can both inject the trial saline and also inject the injectable seemingly at the same time. I guess my thought on that would be oftentimes you would want to give them a trial and see what the benefit is and then have them come back for the actual injection versus mixing the two and having some of those volumetric differences, particularly when we're talking about small volumes of injectables, 1 cc to 3 cc injections, where adding another cc of a saline solution could make a significant difference in regards to what their ultimate outcome is once the swelling goes away.
Yeah, I agree with that. I think, again, Francesco had mentioned about, 3D images, and we had a previous podcast on PRP, and we were sort of discussing about best type of analysis for fat retention. And I think similarly, I don't know if there is better imaging that exists. Do you think an MRI or some type of other imaging would have provided more accurate analysis? Is it necessary?
I think it certainly could, but the issue is obviously cost and the inconvenience of undergoing a more either costly or even an invasive imaging technique. So I think we're always looking for the ability to measure our outcomes with the least amount of inconvenience and cost associated with that process, particularly to the patient. And 3D imaging may hold that potential, and we'll just have to wait to see what comes in the future.
Great. I applaud the authors for trying to answer what is sometimes a difficult question that's really perpetuated by so many different people who are just able to do injections. And, I feel so privileged as a plastic surgeon that you were able to offer our patients, the whole armamentarium of non-surgical and surgical options. And I think we're able to really serve our patients best. I think with that, we'll end our discussion of this article. Thank you, everyone, again, for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us in the Apple iTunes Store. Also, remember to tune in to the other 2 articles we'll be discussing on this month's podcast. And finally, please join us this month for our monthly journal club on Facebook, where we will be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not yet done so already, and it is there where our monthly journal club takes place. And once again, thank you so much, Dr. Nguyen, for joining us.
Thank you for allowing me to participate. And I really want to commend the resident ambassadors on their great analysis of these articles and really insightful questions.